हमार साहब જોઈન થાય એટલે ચાલુ કરીએ.
જીગનભાઈ બધાને પેનલિસ્ટ ને એકવાર હાઈ કરવા કીધું એટલે વોઇસ બધું બરાબર ચેક કરી લઈએ.
હા અંજનભાઈ તમે તો કરી દીધું, બાકીના પેનલિસ્ટ
હિમાંશુભાઈ
સરનો માઇક મ્યુટ છે.
એક મિનિટ.
શિવમભાઈ
ખમાર સરે જોઈન કર્યું છે. ગુડ ઇવનિંગ ખમાર સર.
ગુડ ઇવનિંગ ખમાર સર.
ગુડ ઇવનિંગ.
હિરેનભાઈ કેવું છે? ચોરાણી સાહેબ તબિયત ઓલ રાઈટ?
એકદમ ફાઇન.
હેલો
હિમાંશુભાઈ ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ. ગુડ ઇવનિંગ ટુ એવરીબડી.
શિવમભાઈ
ખમાર સાહેબ. ગુડ ઇવનિંગ ખમાર સાહેબ.
ગુડ ઇવનિંગ હિમાંશુભાઈ પરમાર.
ખમાર સર મજામાં?
હાજી એકદમ.
હવે
સંભળાય છે સર? હેલો
9:05 ચાલુ કરીશ.
શિવમભાઈ
યસ સંભળાય છે સર?
હા યસ ડન શિવમભાઈ.
થોડી સર બીજા ડિવાઇસ માં ચાલુ કરવું.
હા હા બસ બસ ગ્રેટ.
कहाँ चले गए थे तुम? हम तब से ढूंढ रहे थे तुम्हें.
સમીરભાઈ એઓપીજી ગ્રુપમાં ઈબી વાળા ગ્રુપમાં કોને બધા ઈબી ખાલી એકવાર જોઈન થાય એમ?
જીગનભાઈ હું કરું?
હા તમે મેમ મેસેજ તો મૂકે પણ તમે રિક્વેસ્ટ લખી દો ને.
હા હું રિક્વેસ્ટ લખી દઉં.
હે ના ગળી નહીં, લીંબુ તો નાખવા.
બધાને ઓપીડી
ઓલ સેટ જીગનભાઈ.
બસ સમીરભાઈ કે એટલે ચાલુ કરીએ.
એક મિનિટ પછી.
હા હિમાંશુભાઈ
ક્યાં ખોવાઈ ગયા પાછા? છે
ના પણ
યસ ભાઈ.
આ ક્રિટિકલ કેર ચેપ્ટર સેન્ટ્રલ માંથી કોઈ થવાનું છે જોઈન?
ના ના નથી લાગતું. મોસ્ટલી વી વિલ સ્ટાર્ટ.
ચાલો જીગનભાઈ સ્ટાર્ટ.
ચાલો. ગુડ ઇવનિંગ ઓલ. I, Dr. Jigensa, along with my co-MOC, Dr. Kunal Shah, welcome you all for today's webinar. Today's webinar is a part of AOPG Action Plan 2025-26, and webinar is organized in association with Gujarat Pediatric Intensive Care Chapter. So welcome you all. Our faculties, moderators, panelists, and experts are really expert in their respective field, and especially in pediatric intensive care. So we will enjoy the science as well. So first of all, I request Dr. Jagdish Khamar to give welcome note.
Dear friends, colleagues, and seniors, I welcome you all for the Expert Connect, the webinar series under the AOP Presidential Action Plan. AOP Gujarat and Gujarat PICC in collaboration of this series is going to useful for the learning many emergencies and office practice. Our today's theme is issues in office practice emergencies and how to handle and when to refer. I welcome OBs of Central IIP and EBs of the Central IIP. I also welcome past President AOP Gujarat Dr. Tusharbai, President-elect Dr. Janknaben, AOP Secretary and Brain after the webinar Dr. Samir Bhai and all EBs of the AOP Gujarat. I also welcome Chairperson IAP PICC Dr. Arun, Honorary Secretary IAP PICC Dr. Vinayak, Chairperson Gujarat PICC Dr. Himanshu, Secretary Gujarat PICC Dr. Amit Bhai, moderators and my friend moderator and my friend Dr. Khanjan, experts Dr. Nirmal Choraria sir, Dr. Parmanand sir, and panelists Dr. Hiren Bhai, Dr. Himanshu Bhai, Dr. Nitin Bhai, and Dr. Shivam. My special thanks and welcome Dr. Angelica and Action Plan in charge Dr. Jigen Bhai and Dr. Hemant Sogani. I also welcome zonal in charges Dr. Dhiren Bhai, Dr. Manish Bhai Mehta, and Dr. Teja Sapani. And I also welcome all the attendees of this webinar series. Thank you. Jai AOP, Jai Hind.
Thank you, sir. Now I request Dr. Himanshu Tadvi to welcome all and say a few words about today's webinar.
Himanshu, you have to unmute.
Mute.
Yes. Good evening and thank you so much, Dr. Jigen. On behalf of Gujarat Pediatric Intensive Care chapter, I would like to thank Dr. Jagdish Khamar sir and Dr. Samir Shah for taking an initiative and starting this joint webinar series Expert Connect along with our Encounter series. And this series we started, I think this is third webinar, and this is very interesting and enriching with the clinical experience. We are most of the time we are discussing our clinical cases that we came in our day-to-day ICU practice. And that will be very helpful for our practicing intensive care people as well as pediatricians also. Yes, and this is third case series, webinar case series, which will be definitely very helpful to all of our GPICC and AOP Gujarat members. Without wasting much more time, I would like to thank Dr. Jagdish Khamar, Dr. Samir Shah, Jigen, Dr. Krunal, which is taking too much efforts to make this event happen every month. And many of times the momentum gets slow after one or two efforts, but Dr. Krunal and our team of Dr. Khanjan all are doing very nice to continue this webinar, and that we will continuing. And I would like to thank our experts, Dr. Parmanand, Dr. Nirmal Choraria sir as a expert, and our panelists, all other. So without wasting much more time, I think we should start. Thank you so much again.
Thank you so much, Dr. Himanshu. Now I request our AOPG Secretary, Dr. Samir Shah, to give highlight about this Expert Connect program.
Dear friends, very good evening. And first of all, from bottom of my heart, I really thank the Gujarat Pediatric Intensive Care Chapter office bearer who are really accepted our invitation generously, and we able to connect today in this Expert Connect along with the Encounter series of this intensive care chapter. So this is the the two series what we are going to today with connected with them. This is our fifth series of webinar for the AOP Gujarat Expert Connect. After the completion, starting with the adolescent chapter, followed by the ID chapter, NNF chapter, and neurology chapter. This is now we are connecting with the intensive care chapter of the Gujarat. Our main aim and objective is added in the our main theme line, that is the issue in the office practice, how to handle and when to refer. And for that, we mainly connected with our all 5 zone experts across the Gujarat. And all the 5 experts from there, what we are searching is the young talent mixed with the experienced experts who are we connected with us to give their expert opinion. So our main objectives of today's webinar and this webinar series is that ultimately our knowledge sharing should be in such a way that only just new knowledge will not help, but it is also experience speaks. And for that purpose, we are mixing every monthly this webinar series along with our expert connect with different category wise. Till now, we had completed the 4 series. Today is the 5th, and next month we are planning interestingly non-academically important topic, and that is about the finance and how we can explore the finance in a startups. That is our main theme. Very soon we will give the details about that. So with this, in short, brief about the expert connect, what we had started since 5th, I hand over the mic again to the Dr. Jigen for continuing the program. And my sincere thanks to all the people who are connected today in this expert connect. And my sincere thanks to our president, Dr. Jagdish Kamar, also, who is taking and accepted my proposal regarding this expert connect. Thanks a lot, and once again.
Thank you so much, Bhai, for your nice words. Now I also welcome Dr. Jankna Sanghvi, President-elect. She is joined just now. Now I request our Treasurer, AOP Gujarat, Dr. Kunal Shah, to give idea about the concept of encounter.
Thank you, Jigan bhai. Without wasting much time, I'll speak in a short manner. Okay, this webinar series of encounter was started with the concept where different private pediatric intensive care people can help each other to understand and get knowledge to treat the difficult cases which is encountered with us in our daily life. So this was a knowledge sharing platform, and it is completely case based, and it is on the practical ground. So we started with this concept, and we are through with the 3rd episode, and many more to come. Thank you so much.
Thank you, Kunal bhai. Thank you. So now we start our scientific session. I think our faculties don't need any introduction because they are well known and well expert in their field of pediatric intensive care. Moderator of today's session is Dr. Khanjan Shah. He is from Ahmedabad. Panelist Dr. Hiren Patel. He is from Disa. Dr. Himanshu Tadvi from Surat, and Dr. Shivam Barsha from Rajkot. Our expert is Nirmal Chaurase. He is very well known Sachin Tendulkar of intensive care. So I request Dr. Khanjan to start the scientific session. Question answer will, you can put your questions in the chat box, and our question answer session will be after once all 3 cases are over, 3 or 4, whatever moderator want to take.
Good evening, everyone. Thank you. And I congratulate the team of AOPM Central IIP to come up through this. So I'll just share my screen and yeah.
So it's visible. Yeah.
Yeah, okay, fine. So basically, when we were given this task to, go ahead with this particular topic where office-based practice may, if emergency lands up, how to identify, treat timely, and refer at a place where it can be managed properly. So these are the 4 emergencies which very frequently would land in your day-to-day practice, and we'll take the help of our panelists and experts to streamline it. So I was just going through our last 12 transports or the referrals which had come, out of which 8 were properly sent. 2 needed sort of improvement in form of a proper treatment or airway to be secured or properly transported, and 2 kids did not require to be go to the higher center and was sent. So let's learn from this experience, and I'll start away with the very first case. So There was a 3-year-old girl. She had a fever going on for 4 days and fast breathing started for 2 days. She started becoming drowsy and breathing seems harder. When she landed into the pediatric OPD, she was drowsy, febrile, tachycardic. She was breathing at the rate of 58 per minute. Her saturations were 86% on room air, and all her accessory muscles were firing. And so now would like Dr. Himanshu sir to, open this with, sir, if such patient lands into a practice or the pediatrician, what are the clinical signs which many times can get missed that everyone should know, and what immediate action you should have or you would take in this particular child? Himanshu sir.
Yes, thanks, Kanjan. So, looking at the history of this child with a febrile illness and with the signs of respiratory distress, the child is tachycardic with all the accessory muscles are working. Child is lethargic, tachycardia. So, all these signs indicate that child is not well. First of all, now if we go the basic approach wise, our purpose in of this session is most important three things we have to keep in mind. We can apply this approach in all other cases also. First, our motive is to rapid assessment, which is like pulse approach, where we, with our experience and rapid clinical examination, like looking the appearance, breathing pattern, and circulation. So looking at the ABC, which doesn't even, we may not need the stethoscope also, just appearance. By appearance, whether the child is active, alert, or child is lethargic or drowsy. So appearance. Second is breathing. As you told, that child is tachypneic, then the child is having a use of accessory muscles, so retraction, grunting. So these all are a visible clue for breathing pattern. Similarly for circulation, whether the child color, by just looking at the skin color and lips, the child is pink, looking pale, or dusky and cyanos. So these kind of three common findings, like just it is 5 to 10 second, hardly, maximum 30 second. So by rapid appearance, breathing, circulation, by this approach, we will classify the child from life-threatening to non-life-threatening, and looking in further more detail by all other clinical finding, we have to take a decision whether the child is having airway, breathing, circulation need immediate intervention or not. So in this particular child, and yes, so first is the taking help of airway, rapid ABC, which is to identify the by appearance, breathing pattern, and circulatory. On that basis, with our clinical experience, we have to find out the red flags. Red flags in the term of airway maintainability, circulatory compromise, and along with that, if any intervention needed, we have to start along with assessment, prepare for intervention. So that will be the basic approach we have to follow in all the patients. Now, in this particular child, as the child is having tachycardia with labored breathing and child is drowsy, so without further more detailed examination, we can say that this child is having respiratory distress, and again it is severe category. So in that, our purpose is to maintain the baby's airway. If it is not maintainable, to the gentle suction, airway positioning, opening of airway, support the breathing by immediately starting the oxygen support by non-rebreathing mask or like that, and meanwhile preparing for establishing the fast vascular access to check the basic lab parameters like blood sugar, whether the child is having hypoglycemia or not, basic labs. So our assessment should be simultaneously going on with the intervention. Whenever we find by this rapid physiological assessment any red flags, we have to start simultaneous action also. Thank you so much. If anything missed, you can add on.
Okay, so very well said, sir. You put out that piece of puzzle very well. That ABC is called ABC for a reason and the priority that we have to put. And also you mentioned that it's the first 10 seconds, 15 seconds are what needed to know the red flags. And you mentioned each and one of them. So these are the signs. If we are in the busy practice, then if you see any of those things, immediately one has to rush and intervention should start, because delaying every second matters. You also said that by non-rebreathing mask, because many times we see that patient comes with the nasal prongs with 1 liter, 2 liter, where the requirement is very high. So the non-rebreathing mask with 10 10 liter of oxygen one should start, and this is what the immediate action should have been taken. Very well said. So now coming to Hiren Patel, sir. So now once you started the intervention in the form of started oxygen, took vascular access and examined the child. Now again you have your own practice to deal with, and now this is a child who is particularly sick. So now what would you tell your junior staff or doctor to monitor in this particular child who's come with severe respiratory distress, query respiratory failure?
First of all, good evening to all. As we have narrated the case and Dr. Himanshu has told us what is our priorities. To monitor such a child, you need a specified person who can look after this child, because we are dealing with a case in a normal general practitioner's general pediatrician scenario point of view. So we have to appoint a particular person who can monitor this child continuously and closely. And for that, as various points narrated by Dr. Himanshu, this CRS score, that is clinical respiratory score, is very much helpful to assess the ongoing changes in the patient as well. And based on that, it is a part of 6 various clinical parameters which are given score of 0, 1 and 2. And all the points are narrated already. So we along with the saturation SpO2 monitoring. So we have to do the continuous saturatory monitoring, continuous clinical monitoring, look whether child is improving after your initial management or not. And without wasting time, we have to keep on accelerating our management part as well. So main parameter, we have to look for the distress part, sensorium, whether child is deteriorating in the sense of sensorium, and third one is dropping this saturations, because we have started oxygen, and if child is still not able to maintain the saturations as per our expectation, then we have to be very alert. So it is a dynamic process in which a particular close monitoring is carried out, and we have to avoid, we have to detect the early signs of respiratory failure, because we don't want such child to land up in a respiratory failure scenario where, if we have not facilities to move ICU care nearby, then we will, and child of course will end up in a problem. Anything
Right,
else
sir.
to?
Right, sir, because this child, one thing is, you rightly said that there needs a particular person to closely monitor, because it's very dynamic situation. It changes every minutes to minutes, number one. Also, your interventions which you have started, are they in the right track? Are the child is improving or not? And as the clinical condition, what we saw in this particular child, he is at the borderline of respiratory failure as well. So, any point of time cardiovascular collapse can happen. So yeah, the monitoring is very important. And as you said, it is dynamic. So one has to be, you cannot leave this child bedside for a minutes also. Coming next to Hiren sir, again to you. Suppose you started the treatment and now you decide this child to send. So what are the criterias, or which, as a practicing pediatrician, should keep in mind, like when should they refer a child with respiratory distress, and where will they should refer that particular child?
This is a child with respiratory distress, of course, and we have started the initial management. During the course of management, if child's sensorium is deteriorating, if child is getting more and more hypoxic, or the sets are not improving even though after giving the optimal oxygen therapy, if child is not responding to the supportive management for circulatory stability as well, and if there is a child signs of any paradoxical breathing starting, this is the point where we have to be alert, and we have to prepare for this child to send at such a center where this child, if land up in a respiratory failure, can be managed well in an ICU setup, along with, if required, availability of mechanical ventilation as well. And such child, if required, during this decision to transfer to other center, if required, we don't wait to along with only oxygen. We can also do intubation and then prepare for the referral.
Absolutely right, sir. Recently, like few months back, we got a call from Bhavnagar, like, and the very particular question the referring pediatrician asked was like, do you have ECMO facility, or do you have ventilator available? So these are very important thing, because if you're sending and that particular place, if ventilator is occupied or something, and then if child needs to be shifted in that sick condition, it becomes very tricky to explain to parents. So communication to the referring point, and apart from these are the very warning signs which would need that the child is deteriorating and needs early referral. Coming to Shivambai is again dynamic intensivist. Shivambai, if you receive this child, so how would you expect a referring doctor or pediatrician to transfer this particular child to you?
Yes,
Dr.
sir.
Shivam.
Yes, sir. First of all, as Kanchan sir rightly said, communication is the most important part for a transport. If you don't communicate with the referring doctor, first you decide where you want to send the patient, and you need to communicate with the doctor there the condition of the child and what support, what thing you are suspecting. In that case, whether that facility is available there or not. As important as communication with the doctor is, similar communication with patient is also required. A patient has come to you in a critical condition. He has come you with your for considering you are means you are a doctor with trust in you, and he has become so bad, and now again it is a trauma for him. He has to go to some other place to continue treatment into an unknown place. So you need to communicate with the patient the need for transport, why he needs the transport, and also you take them into your talk with the. You can also arrange for a communication with the doctor with the directly with the patient regarding what treatment would be provided there. Second important thing would be to document the vitals and the interventions what you have given to the child to the communicate with doctor, and also document it on your case sheet, so that medical legally also you are safe, and any condition, what doses you have given, what medications you have given will be clear to the doctor who has received the child. The center would also be prepared for what the child is coming, what is that, what they need to do, what intervention they would be requiring. Another important thing would be to accompany the child with a trained personnel. So with an ambulance which is already a personnel is present who would know how to do a bag and mask ventilation, who would know suction, who would know how to intubate the child. It would help us if there is any some complications on way to the referral side. Meanwhile, you need to continue oxygen therapy during transport. NRBM, if possible, the best thing would be to secure the airway so that there is no other issue. Maintain an IV line and continue antibiotics if you've already started, and also keep the child warm during transport and monitor whether the child is breathing properly or not. These would be the most basic things which would we want the referring pediatrician to take care.
Very rightly mentioned, Shivam that apart like airway has to be secured. That is most important thing. And I remember last year, 1 year, we had 4 kids dying on the way with respiratory distress when the airway was not secured, and one could not intubate on the way. So very well said. Documentation, communication, apart from the specific and right treatment to continue is very important on the way. So now I would like Dr. Nirmal sir to give his insight on a child who is with respiratory distress or failure for any condition, be it bronchiolitis or pneumonia or foreign body needing bronchoscopy or surgical condition, but child needing is in respiratory distress. What you have to say for that particular child being transported and picked up early by the pediatrician. Over to you, Nirmal sir.
So first of all, thanks to AOP and Gujarat Critical Care Chapter for arranging this webinar. Am I audible?
Yes, sir.
Yes, sir.
Yes, sir.
Okay, fine. So this is the first case, Kanchan. I think you are very well represented the first case, and it's a case of respiratory distress with maybe impending failure. And whatever is the condition, as you rightly said, if the respiratory system is involved, and Himanshu very well said, that we have to do the pediatric assessment triangle, which we do to do ABC, whether it's the airway, breathing, or circulation. So this is very, very important. And here I think for pediatrician, I will divide into 3 groups. One is the pure office practice, the people who are just running the office practice, who do not have the nursing facilities or nursing home. Second, people have got the nursing home, but there is basic pediatric care they can take. Third is we say the critical care level 2, and last is the tertiary care center. So we have to decide what kind of treatment we have to provide. Here, the case which you have presented here, this case definitely in the respiratory distress and maybe impending failure. This child can deteriorate any time. So what is required is, as Himanshu rightly said, first stabilize the patient. So we have to have a proper clinical assessment of airway, breathing and circulation, properly manage the airway. We have to do the perfusion, has to be maintained. And I think Himanshu and Hiren and even Shivam, all three have very well explained how to do the clinical monitoring, how to do the gadgets monitoring also. But here I would like to say what our clinical assessment, and that is the regular periodic assessment, not necessary that each and every child has to be transferred immediately. First, we have to do the stabilization. As he rightly said, start the oxygen. That's the first part. IV secure. Give first hour antibiotic. It has to be given the first hour when you are suspecting any infection. So that is very important. And second thing, I think it's very important to assess how long can I keep this child under my care. Sometimes maybe the child is having only this test, but there are no signs that this child may land up immediately with failure. So 6 to 8 hours or 12 hours is a period where you can observe the child. But in spite of giving proper oxygen therapy, child is not improving. And the first hour is very, very important. And I think that will give a clue whether this child will settle in my nursing home with the existing facilities with me, or this child will need immediately transfer. Now, again, I think when such scenario arises, what daughter may be the underlying cause, how far is the center where you need to transfer? That is again a very important thing. Maybe it is in the vicinity of 1 or 2 kilometers. Then the things are easy. You can transport this patient within half an hour or 1 hour at the most. But if you have to transport that patient to around 20 kilometers or 30 kilometers, 40 kilometers, it is always better to transfer in time. Because many times we have seen the child deteriorates, because when the last moment the people will say, oh, the child was maintaining with 8 liters per minute oxygen, 95% saturation, and suddenly child crashed. So I think no child crashes very suddenly. If we monitor properly, we can transfer the child very well. So most of the points have been very well taken care. The most important is securing the airway. And I personally strongly feel that now whatever level you practice, we should have one oxygen cylinder in our clinic. That's why we should start immediately oxygen. That is very important. IV line has to be secured. And as the pulse course we do, at least intubation facility should be there. It's always better to intubate in the clinic rather than intubating in the ambulance. So if required, it's fine. But it's always easy to intubate at the time where you are doing in your own setup and then transport the patient. So the mode of transport is very important. By which mode you are transporting the patient. Simultaneously also see whether the oxygen cylinders were are in the properly full or not. Sometimes it may happen that it was not checked when you transport the patient and the oxygen cylinder was empty. The most important part when you transport the patient, the medico-legal aspect has to be seen. And I think Shivam has very rightly said, we have to take the consent, we have to put down our notes at the time of transport, what is the condition of the patient, and during transport also, it has to be transported, as rightly said, by the trans staff, and every 15 minutes you have to put a note. What are the vitals, means heart rate, respiratory rate, and all these things, IV line going on, how much fluid you have given, what is the saturation level, that has to be recorded. So there are the forms in the transport form which has to be properly filled. And Shivam very rightly said, both the sign, the recipient and આપને જેને મોકલવાનું છે એ બંનેને ક્લિયર ખબર હોવી છે what patient we are transferring and what patient needs to be received. So accordingly, the arrangements have to be made. So I think most of the points are very well covered. Most of the emergencies in pediatric practice, they are most of respiratory. And if we don't diagnose in time, then we'll end up with a problem with cardiorespiratory decompensation and cardiorespiratory arrest. So that has to be picked up in time, managed in time, and if required, transferred in time. That's what I would like to say. Thank you.
Very crisp and very clear. So the points right from stabilizing, identifying, stabilizing, intervening, not rushing into things and then transporting properly. And as you said, if airway is secured, it becomes much easier for that particular patient to be transported to the referring point. So thank you, sir. Now coming to the a second case. So we had a respiratory case. Now this 11-year-old boy, he had a history of trauma a few days back and now developed cellulitis last 3 days. He is running high grade fever. He has become irritable and urine is less and he is pale. On finding, as I said, he was irritable, febrile for the 11-year-old, heart rate of 160, saturation he was maintaining, pulses were feeble, blood pressure was hypotensive, periphery cold, and local examination shows left foot cellulitis. So one of the, very nightmare kind of emergency, even intensivist foot phase. But suppose if such child comes to the pediatric office, so my question to Hiren sir is like, this is it's pretty clear that child is in shock. But if many a times signs of shocks are not that clear, so what are the early signs? And if child is in shock, how would you or what you one should do in the very first minutes when they receive the child? Hiren sir.
Kanjan, we look at this history and clinical parameters shown here. Child is 11-year-old and heart rate is 160. So that is quite high compared to. We see a febrile child with some tachycardia, but we have to look whether it is proportionate to the degree of fever or illness. So early indicator for such a septic child going into the shock will be a disproportionate rise of heart rate compared to the temperature. So that one. Another is the sensorium. If child becomes playful, child becomes irritable or drowsy, that has to be considered as early signs of shock, along with the CRT. If CRT more than 3 and increasing, definitely we have to be alert. And another is extremities getting cold. Child is febrile, so core temperature is high, but extremities are cold. So that is another early warning sign for shock. And along with that, you will find some decreased urine output and decreased intake as well. But one thing we have to remember that don't wait particularly in a case of septic shock, don't wait blood pressure to be low, because this is a late sign, particularly in cases of this septic shock. Falling of blood pressure comes quite late. So with early signs only, like this tachycardia, sensorium, CRT increase, we have to act fast. And this is called the golden hour. Our aim in this first golden hour is to first detect the condition and severity of whether child is in shock or not. Second thing, we have to try to reverse this shock within this 30 minute or at least first hour. And third, we have to prepare for the complications as well during this period. So for that, we have to establish the basic ABC. We have to correct the ABC for airway suction and clearance of airways should be done immediately. For breathing, we have to give the oxygen support with high flow if required. And for circulation, we have to take the IV access immediately. If not possible by IV, we can go for intraosseous as well, but we have to establish the IV access immediately. And we have to start the fluid resuscitation with a bolus dose of normal saline or RL. Normal saline is more preferred, with about 10 to 20 ml per kg bolus in 15 to 20 minutes we can give, and reassess the child. If by after this bolus child is parameters are improving, then there is no need to further bolus, then we can switch out to the further management, but you can repeat 1 or 2 after assessment of the first bolus. But now the recent study also said that in septic shock you haven't to push fluids, because it may further delay the recovery period as well. This is the studies we recently came out. So we have to use the fluids cautiously, particularly in septic shock as well. And when you think that fluids are not helping and child is vitals are not stabilizing, then we have to go for the ionotropes as well as early as possible. So our aim in the first hour is to reverse the shock. If not possible to reverse, at least avoid that what we called warm shock to going to the cold shock. Kanjan Bhai.
Right. As you very well pointed out, sir, first we talk about the early signs and late signs. So tachycardia disproportionate to fever, delayed cap refill, poor cold extremities, poor even organ perfusion dysfunction in the form of altered sensorium or low urine output. In dengue, many times we see a lot of abdomen pain. So when there is a mesenteric ischemia, so these are the signs which are one should not miss. And as you said, ABC immediate actions. So we follow the surviving sepsis guideline. Fluid bolus judiciously. You don't just push it because FEAST trial and other trials show that even high fluid can also be detrimental, but always monitor the signs of improvement as well as worsening when giving fluids. This is septic shock, so needs of antibiotic in within first hour. If there is hypoglycemia or anything needs to be corrected. And as you said, this is a case where a lot of efforts are will be needed in coming sometime. So you anticipate also early. So that brings me again to you, sir. Sir, how would you monitor? You have given bolus, given antibiotic, and you saw that BP has come up a bit. Perfusion has improved a bit. Sensorium is still same. Urine, it's too early to comment anything. So how will you monitor this particular child? Because there is a
Yes, we all
cellulitis in
agree.
the
This is a dire emergency. Septic shock is a dire emergency, and we cannot leave the child, and we cannot wait that child will come out by starting the management. So we have to monitor the vitals, of course. We have to look at the what are the heart rate, what are the saturations are maintained or not. Along with that, the blood pressure monitoring is important. If possible, arterial blood pressure monitoring is the ideal thing, but you can monitor with other non-invasive methods as well. And if possible, CVIP monitoring will be desired if possible. But along with that, the simple indicators, along with the heart rate, that CRT monitoring, the color of extremities, whether it is getting warm or not, the face of the child, activity and sensorium of the child is quite helpful to see whether child is still in the shock or child is showing any improvement. And one lab parameters, that is ABG, is quite important at this stage. So we have to monitor the ABG, and along with that the lactate level, because for the prognostic value as well, lactate is very much important. Uh, so these are the and titration of ionotropes drip if we have started. And so that is the main we think I would like to monitor.
Rightly, sir, you said, but this child suppose lands up in ICU, we started the bolus and antibiotics and everything. To get into the invasive blood pressure monitoring and all can be, it needs a place where, intensive care monitoring can be done. But as you said, this is a dynamic situation. Every minute matters and things would change very fast. So clinical, laboratory wise, as well as the parameters which you mentioned, all has to be looked, because many times you see one parameter improving, but then if other parameter is not improving, it's a red flag. So now that brings me to Shivam bhai. So this child, if this patient comes to the OPD and you started the primary management of the golden hour, so where will you refer this child and when will you think of referring? Suppose for this particular child or other shock categories, if you can tell about. Let's say if child comes with diarrhea, vomiting, and dehydrated, and in hypovolemic shock. So that shock is how different from this particular septic shock. Shivam.
So, in particular, in this case, when would be right now? So, the case which has come, it is a dire emergency, a septic shock, as everyone has already said. The best time would be to refer it now. So for septic shock, again, if at all you have admitted and you are looking after some, you have a small hospital where you can look after, you can give fluids or something. If you have given a fluid bolus and the child is not improving, if the child's sensorium is worsening, mental status is not worsening, if at all you have a gas done and lactates are rising, if you have already started inotropes, then it is the best time that once you started inotropes, you need to refer him. If the sensorium is worsening, you have to refer him. If you don't have facilities for gas, blood culture, or another inotropic support or monitoring particularly, then it would be you have to refer the child. As particularly said, other causes of shock usually are, one is most commonly which we come across, though it has come decreased now, but hypovolemic shock due to diarrhea, vomiting, and all. In such cases, maybe after giving a fluid boluses, you can wait. Right, so as Hiren sir has rightly said, for septic shock, it is no means as less fluid is more, but for hypovolemic shock, you need to give fluids. If you've already given 20, 30, 40 ml per kg of fluids and the child is still not improving, then you need to refer that child. Other types of shock are distributive shock, that is one septic shock. Other is an anaphylactic shock. So anaphylactic shock is an emergency, and everyone must know how to treat an anaphylactic shock because it does not give time. So if you have to keep adrenaline ready. Even if you are doing an office practice, and adrenaline you have to administer to that child, and you have to refer the child there. But at least adrenaline you have to give, O2 adrenaline. And again, the last type of shock is a trauma, means due to trauma, compressive shock like cardiogenic shock, and also like pneumothorax. Those all are emergencies. But the only thing which you can do, if you don't know which type of shock, you start him in small bolus, start him on inotropes, and refer the child. I think I'll not like to go more detail. Sir could add if anything is.
No, Shivam bhai very rightly said. Like if one in the practice, if there is a diarrhea, vomiting, give a bolus and reassess the child. Those are the easy to and fast to treat the child. Obviously, those kids do sometimes have element of distributive shock also. Because that's where, if there is a history of diarrhea, vomiting, and we think it is hypovolemic shock, but it could be an added symptom of septic shock. So as you rightly said, fluid bolus and the management which one starts, see the improvement and how far or how long that sustains. But yeah, that's when one should think of the referring a child. So you mentioned need for fluid bolus, rising lactate, inotropes need, and one more thing, like this septic shock kids do, if they are in distress and everything, a lot of their cardiac output goes towards the respiratory muscles. So they need, even though they're maintaining the saturation, needs airway secured so that you can sedate the child and use that cardiac output to the vital organs. So even those kids would need to be shifted to the care where all this can be done. And invasive monitoring is of vital importance. So Himanshu,
Ranjan
sir, I'm
bhai,
sure.
here we have to be very specific in choosing transport vehicle as well in such a cases, because
Right, sir. Right, sir. We'll come to that, sir. Yeah.
this child will require accompanying by some infusion pumps, multipara monitors.
Absolutely, sir.
that-
Absolutely. We'll come to that. We'll come to that. So Himanshu, sir, coming to you, I'm sure you receive so many kids with the septic shock. So if I ask you what is the most ideal way that you will be happy that you receive a child of a septic shock, so what that would be? Himanshu, sir.
Yeah. So, Ranjan, basically this child, particularly this child, the child is in hypotensive septic shock. Okay.
Right.
And besides that, any child with the shock, in a pediatric ICU practice, two most important category of patient which needs special consideration during the transport. One is this shock, and second is the convulsing child or child with the raised intracranial pressure. These two category need special transport facility also. So first of all, we will discuss in a part wise. First of all, the mode of transfer where the ambulance should be fully equipped. So smaller like Omni kind of ambulance is not good mode of transport, because this child will the child with a hypotensive shock will require the constant monitoring of vitals, so multipara equipped. Second thing, oxygen support. Third thing is ventilator also if the child is intubated or need any time intubation. So transport ventilator facilities, so multipara monitor, infusion pumps, and power battery backup also. So the ambulance should be well equipped. Second thing, a child with a hypotensive shock needs special consideration. First, in the point of that, when we encounter a child with shock, we will categorize for this transport purpose only. Hypotensive shock, definitely the child along with the resuscitation, his airway has to be secured. So child should be intubated before the transfer to prevent the sudden deterioration on the way of transfer to the tertiary care. Second thing, even though compensated shock, but if we are anticipating further delay in improvement of parameters, so child with the compensated shock might decompensated during the transfer if the distance is much more. So in that also, when the anticipated further deterioration of compensated shock, still the airway to be secured. So second point is securing the airway when the hypotensive shock or anticipating further deterioration. Third thing most important is the distance in a shock, particularly shock patient. Again, as Nirmal sir appropriately told in first case, the distance is most important, especially in a shock. If the distance is 1 or 2 or maximum 5 kilometers, that time will be very less, 5 to 20 minutes. But when the distance is much more, then the resuscitation should be simultaneously going on. It has to be going on. So in that case, the child will require to continue the fluid therapy along with the vasopressor or inotropic support. So for that, infusion has to be working. And third thing, most important is monitoring of the vitals, because when the child has to be planned for shifting, the referring doctor must monitor and document the vitals, communicate to the transferring staff, especially the ICU staff. ICU staff who is nurse carrying the patient or transferring the patient, and same has to be informed to the receiving hospital ICU staff as well as doctor. So that particular transfer period, child should not deteriorate at all. In the past, we had many bad experience that the child, according to the referring doctor, was relatively stable, and when we received that time, child was near about collapse, or in a few occasions, child had collapsed on the transfer also. So during transfer, the level 3 or the ambulance well equipped with the multiple infusion pump and transport ventilator. ICU, as ICU experienced staff is must to manage this child during the transfer process, continuing resuscitation as well as all the infusions. And fourth is the ongoing monitoring, because the vitals may change rapidly in a hypotensive shock. So this is the in a nutshell. And if possible, intubate the child before the transfer, so the chances of sudden deterioration will be avoided and child reach safely to the tertiary care. That's all.
Very rightly said, sir. Like the experience which you shared is very important. And what I would say, ki if you cannot, like if you are very senior or you do not have, you cannot intubate a child or have this, at least have collaboration or coordination with one of your anesthetic friend or someone, at least who can secure the airway, and then you can transfer the child. So very well, you had this complete entire checklist you said. Coming to Nirmal's, now this was a case of where hemodynamics were compromised, and that child lands up into the OPD practice and is being transferred to the ICU care. So, what are your insight and experience about this, sir?
I think most of the points have been very well covered by Hiren, Himanshu, and Shivam. 3-4 points which I have noted is number one, all septic shock cases, whether it's a compensated or a decompensated, means hypotensive shock, it has to be managed a level 3 ICU. So if the septic shock is the most difficult shock to be managed, and child may deteriorate any time. A child may be very well compensated shock, and maybe within hours the child will deteriorate to the decompensated shock. So this child will need a proper care at the level 3 ICU. So once the child has come to the nursing home, where it's a level 1 or level 2 facilities are available, their duty is to properly document the findings, start the IV fluids, manage the first hour management, secure the IV line, give antibiotic first dose, start oxygen therapy, and then try to arrange the transport. Either you can send the patient with the proper trained staff or ask the proper level 3 ICU people to come to receive the patient if the time permits. So I think the first thing is foremost is to patient managing the level 3 ICU. Number two, the points are covered, but I am just summarizing the things. The most important nowadays, our new sepsis guideline, they say, yes, initially before 10 years, used to say put 60 ml per kg fluid in first hour, and then if child is not responding, we were used to start the inotropes. But now with the first or second dose of 15 to 20 ml per kg, don't wait for 60 ml per kg. We should start inotrope early. So this kind of cases, epinephrine or adrenaline is the drug of choice. So sooner you start the inotrope, your fluid requirement also goes down and the child responds better. So this we should start inotrope early. Now, it may happen that people who are not well trained of starting adrenaline or noradrenaline, dopamine can be started at the level 2 level because nowadays we don't hardly use dopamine. We only use epinephrine or norepinephrine, depending upon the case. But dopamine can be started with the peripheral line, 10 mics per kg. So when you transport the patient, first you start the IV fluid, as rightly said, give 30 to 40 ml per kg, start inodrop. Epinephrine is the drug of choice in this case because it's a decompensated shock, and if it can be given by peripheral line, but only thing your dilution should be 5 times the dilution. So before you transport, at least IV fluid should be given. Adrenaline should be started, and as Himanshu rightly said, these are the patients who need to be secured airway, intubate the children. My only point of caution would be that if it has to be intubated only by a person who is expert in intubation. Because if you fail intubation sometime, the child may crash and child may go in sudden cardiac arrest. So it is always better to prime the child with adrenaline first, and then you do the intubation by a really competent person who can intubate with the first air. That is very, very important. So here, patient will not give you time, and patient will suddenly crash. So that is the point number 2. And the point number 3 is proper monitoring and transport by trained people. That is equally important. And once patient comes to the level 3 ICU, then this patient is very periodically monitored. First initial few hours, maybe every 15 minutes or half an hour, and then the regular monitoring. The patient is hooked to all kind of multiple parameters. So we do the cardiac monitoring, respiratory monitoring, urine output monitoring. Nowadays, most of the centers, they don't do the CVP monitoring because now we do the bedside echo of each and every child. So functional echo is done. Your fluid status is decided. Cardiac contractility is decided. So proper monitoring is done at level 3 ICU. That's all what I want to say. So septic shock is really a very challenging and difficult shock to be treated. Hypovolemic shock better can be treated at level 2 because most of the time the cause is like gastroenteritis. Once you manage the fluid well, most of the children, they do well. I think most of the points are very well covered by the panelist.
Rightly, sir, you just mentioned each and everything very clearly that the why it is so important, and this is a nightmare even at the level 3 ICU because these children have very dynamic pathophysiology and at multiple level things are changing. So yes, even picking up to transport is a difficult task, specifically if you are practicing at a remote place. So one of the challenging case. Now coming to the third emergency, again the second most emergency after respiratory distress being,
I would
this is
like, Karan, only one thing I would like. When we are
yes, sir.
discussing the critical care, I think
Yes.
we have discussed the 2 cases, and the most important part is the counseling. See,
Right.
when management, we are doing whatever counseling we are doing, it has to be audio-visual counseling. So
Right.
whatever we explain to the parents or relative, it has to be recorded. Sometimes they will say, when my child was fine when we brought the child, and the child has crashed because of your treatment. See, so I
Right.
think the counseling part is very, very important when we manage the critical care patients.
Right, sir. Rightly said. Most of the ICUs now doing this at remote place. Also, when there is someone is explaining or before transporting, documentation as well as this audiovisual recording is important. Well said, sir. Coming to the third case. This is a 10-year-old boy, known case of epilepsy, poorly compliant to meds, and now has a breakthrough seizures. Seizures went on for 30 minutes, generalized tonic-clonic. Apart from that, no specific past family history. That this child, an examination, his temperature normal, was tachycardic. Is when he arrived, saturations were 84. He was actively throwing seizures. I don't know whether monitor was picking it up or actually child was hypoxic. So now I'll start with Hiren sir. Any
Yes.
child who comes up with the seizures, active seizures in OPD practice to the pediatrician, irrespective of the reason, be it febrile seizure or epilepsy or whatever. So what are the immediate action one should consider and why it is very important to treat these seizures very fast? Sir.
Here, child is non-case of seizure and child is convulsing since last 30 minutes. So definitely child is in a status epilepticus stage. So every minute counts here. Yeah. So our first priority is to stabilize the vitals and we have to look for the ABC because child is convulsing since long. So there will be lot of secretions in mouth, oral cavities and nasal cavity as well. So we have to first clear the secretion, give the proper position so that secretions do not obstruct the breathing pattern and then look for the breathing pattern. And if saturations are low 84, so we have to give the oxygen support as well and monitor for the saturations as well, and at the same time we have to take rapidly the IV access so that we can stabilize the circulation, start the IV fluids. And now our first priority is aim and goal is to primary goal is to control the seizures. For that, our first line, benzodiazepine is the drug of choice, and my preferred drug is lorazepam, or you can use midazolam as well. Lorazepam in the dose of 0.1 milligram per kg bolus, or midas in the dose of 0.15 to 0.2 milligram per kg as a bolus you can give. But somehow, if you are not able to take the IV access immediately, then keep handy that Midas spray. So you can at least give Midas sprays repeatedly, repeat for 4 to 6 spray, up to 6 sprays as well. And meanwhile, you have time to get IV access as well. So our primary goal is to control the seizure as early as possible, and in some cases if you think get saturations are okay control with oxygen, then seizures are not still control after first dose of benzodiazepine, you can after 2 to 3 or up to 5 minutes you can wait and give the second dose. But if you think that it is not going to work, then you have to think about the second line of anticonvulsants in such situation. And at the same time, child is febrile here, so we have to control the temperature as well with the use of tapis posing and giving some paracetamol IV if required. And along with that, don't forget to monitor the glucose levels. If by chance there is a hypoglycemia, your first primary line anticonvulsant are not going to work. So we have to correct the glucose level as well simultaneously. This all needs to be do in a simultaneous way with the help of 2-3 staff or doctors as well. And regarding your second question, that is why it is important to treat seizure immediately, because particularly in case of status epilepticus, every seizure there is lot of neurons are firing, so every minute counts, and there is neuronal damage occurring in the brain. So whatever the time is lapse to control the seizure, there is more chance that more and more neurons are damaged, which will lead to the brain damage in the short term as well as long term. In the long term, there may be some cognitive dysfunction or even motor dysfunctions are there, intellectual impairments are seen, even some cases of with prolonged seizures, you will find this mortality will also go rise if we are not controlling the seizures in time. So to prevent the this brain damage and to prevent the mortality, we have to act fast, act effectively, and control the seizures as soon as we receive the child at the earliest.
Absolutely right, sir. Also, there is if the prolong the seizure, more likely it turns into the refractory and super refractory because there is internalization of receptors and that sort of things happens. So we need to aggressively treat the seizures. And you rightly mentioned airway breathing and circulation takes the priority. We take an IV access and give lorazepam, control fever, check sugar and correct it if that is the reason for seizure. And that brings me to you, Shivam. Today only I received a child who had a seizure, typical febrile seizure, and a medical officer at referring point gave lorazepam, and child had a little bit of hypoxia and all. So, if two questions to you, Shivam. One is if what will one should monitor while giving these drugs, and second is if seizures are not stopping and while you are preparing to transfer, what other things you should be doing to this particular child, Dr. Shivam.
Yes, sir. So, first of all, as mentioned, what medications, initial medications which we give for the seizures, most important is maintaining airway, breathing, and circulation. And once those are taken care of, I will not go into detail on that. The medication which we are giving initial, that is midazolam or lorazepam, so they, the benzodiazepines, we are giving boluses. So first thing which we need to see is respiratory depression. So most of the
Absolutely.
cases may cause respiratory depression. So monitoring of the saturation, respiratory efforts, and heart rate. Those are the important things which we want to monitor while giving the anti-epileptics, especially the benzodiazepines which we are giving as boluses. Once it is not being controlled by those benzodiazepines while we are preparing for transfer, in this case, we should means one of ways three, we should take history regarding whether it is first episode or repeated episodes or so. If it is a repeat episode, as in this case, he was not compliant with the medications, maybe once we know what medications he was on and we load him with such medication, maybe we would be able to stop it or so. Sometimes if diagnosis is already made, in some cases we know that it is West syndrome or this what better anti-epileptic we could load. That also we can do while we are preparing for transfer. And maintaining airway and breathing circulation is already told. And other most important thing in this case would be counseling of the relatives. That though in this case they know the condition and all, sometimes when there is first episode of convulsion, even febrile convulsion, it is what I would say is rather than the respiratory distress or septic shock, relatives would be more concerned about convulsion. So though it is febrile seizure, they would want why this seizure has occurred, why this has occurred, and they would want to know why you are referring and all. In septic shock, they would not be worried. We would be worried much. They would be like, it is okay, they can have okay. But for conversion, it is dire emergency for them. So we need to counsel the relatives, also calm them down. And while we are preparing for transfer, take a history. And if any other, we could load them with anti-epileptics, either phenytoin, levetiracetam, sodium valproate, phenobarbital, whatever is available with us, and monitor them properly till the transport team arrives.
Absolutely right. Himanshu sir, once I am at my practice point, if I've given the benzodiazepine, seizures are still, sensorium is still not okay. Child would be obviously drowsy with the medication. Seizures have somehow stopped, but again had one more episode of seizure. So at what point the doctor or the practicing doctor should think about referring this child, number one, and what facilities should be available for that particular, so that to that place they can refer this child.
Okay.
Himanshu sir.
Yes. So see, Khanjan, almost all the pediatrician colleagues receive in their regular practice a child with the seizure. 80 to 90% will be the febrile seizure, but many a child with the convulsion where first line properly given AED has failed, child is still convulsing, and child needs second line AED. That at that point only the pediatrician should keep his mind's antenna high, that whether I am dealing non-febrile, not a simple febrile seizure or febrile status, it is something else. So as soon as second line AED is needed to control the seizure, the pediatrician has to start thinking about the refractory status or super refractory status. First thing I would like to emphasize. And second thing, the most important practical aspect is any child presented to our emergency room, convulsing child, we have to treat them like a status epilepticus only, because practically a child has thrown seizure at home. They realize the emergency situation, they reach to the hospital. So almost 15 to 20 minutes, even as small as nearby place, it will take. So any child presented to us in ER convulsing, first thing we have to on a lower threshold, that treat him like a refractory seizure only, refractory status only. Second thing, a child with the need of second line AED with primary first line AED full dose given still convulsing, that child will definitely need sooner or later ICU care. Third indication is a child having status epilepticus without fever and not a known case of known case of epilepsy, because known case of epileptic seizure, they throw seizure, but as soon as you load the some AED, they will stop. But when the seizures are ongoing, we have to find out the other reason. As we discussed in last webinar only, nowadays besides febrile seizure, the acute fever associated prolonged seizure, other diagnoses like viral encephalitis, some necrotizing encephalitis, autoimmune encephalitis. So other many etiologies which we were not seeing in the past, now they are coming in more frequent differentials. So the third important thing we have to remember is that a child with ongoing seizure, we have to start about the super refractory seizures etiology. And fourth, when the child is having ongoing seizure activity, where the child airway become compromised or hemodynamic stability is compromised, so in that anticipation, child need to be transferred as soon as possible to the tertiary care. And one point which related to this discussion only, what we observed, that when the child's presented with the status epilepticus to pediatrician, usually in a hurry or in the lack of availability of the first and second line, all the AED, usually the loading dose of first AED is not proper. So before transfer, I suggest our colleagues that we have to give proper loading dose of first line AED, repeat it if needed, and then move to second, because if we do not load with the proper dose of AED, then seizure will not going to subside, and that will be more and more refractory. As we discussed, that when the seizure lasts more than 30 minutes, then the possibility of even simple status converted into the refractory status. So proper dose, loading dose of AED should be given along with this all criteria. So the child with this suspected refractory status, with the airway or hemodynamic instability or anticipated super refractory seizure, child need to be transferred to tertiary care.
Absolutely bang on,
And
Himanshu.
Kanjan Bhai, one more point to add, many of us may not be aware that definition of status epileptic timeline has also been lowered to 5 minutes, which
5
was
minutes.
previously considered 10 minutes. Now it is 5 minutes only.
Right.
So that we can act fast and we can prevent this brain damage in later life.
Absolutely right, sir. So
And
Himanshu, sir, hello.
yeah,
Yes, sir. Again, like you have almost covered everything, but for this particular child with active seizures and etiology unknown, you are planning to transport this child, or how would you expect to receive this child?
So the mode of transport we already discussed in a shock, that level 3 equipped ambulance with the staff expert in handling the refractory seizure cases and dose of the AED. So ambulance equipped with the monitor, intubation facility, oxygen suction facility to keep the airway pattern. And in this particular child, I think we are dealing super refractory status, because child is having still convulsion on second line AED. So this child to be need to given proper loading dose of second line AED. Child airway has to be secured because his saturation not maintaining, child is tachycardic, his airway also looks unstable. So this child has to be intubated before transfer by RSI method and along with full AED. And during the transport, we have to avoid the hypoxia, maintaining blood sugar. So all the infusion has to be working to maintain the hemodynamics as well as to control the seizure activity, ongoing seizure activity. And third important point, in this child, the receiving center has to be level 3 PICU only, where the ventilation facilities with the pediatric intensive care person and team, if preferably EEG, bedside EEG, because we many a times happen that the active motor seizure has been abolished, but there is ongoing non-convulsive seizure activity. So bedside EEG facility should be available along with the help of pediatric neurologist in case of emergency need arise. Thank you.
Very rightly, you mentioned, sir, that these are the children where, if anything happens on the road, it becomes very difficult to explain, and medical legally also we are answerable. So that brings me to Nirmal, sir. So now the child with seizures, irrespective of the etiology, happens to be in the pediatric OPD and then has the primary treatment and needs to be transported. So what's your take on this, sir? Nirmal, sir.
So, all the three panelists have very well covered this topic. So, any child presenting with convulsion has to be taken as status epilepticus. I think that is very clearly mentioned. So, now the definition, any child presenting with convulsion or convulsion lasting for more than 5 minutes is considered status epilepticus. So, it has to be controlled very well, and benzodiazepam and lorazepam is the drug of choice. But simultaneously, after one dose, even if the convulsion settles, they recommended they do load with the second line drug like levetiracetam or valproate. For these children will all tendency to convulse again and again. So better we should also load either with levetiracetam or valproate or pospinetoin, whichever way you are comfortable, because nowadays most of the centers is still using levetiracetam or valproate as the drug. And if they are not controlled, then you have to just escalate the other drugs and try to control the seizure as early as possible. So I think that message has to be very clearly given by the panelists. The most important is if you don't control in time, definitely there's a chances of hypoxic damage to the brain. I think that has to be very well said. Chances of aspiration during convulsion and hypoxia, both I think we need to be prevented. And most important is very difficult to transport or transfer a child, convulsing child. Is really very difficult because parents are anxious, child is still convulsing in the ambulance. So it is better to stabilize the child if possible, and if the facilities are available, then try to intubate the child, take the control of convulsion, and then transfer the patient. But sometimes it may happen, in spite of 2 or 3 drugs, convulsions are not under control, then proper counseling with the parents has to be done. In spite of the child is still convulsing, we have given our best. This child need to be properly managed at the level 3 ICU. And that's why we are transferring this child to the higher center. But the consent and anything may go wrong during transport, that consent has to be taken by the parents. Another point I think very well covered by Himanshu, and nowadays we are seeing so many patients of neurological disorders like encephalitis, viral encephalitis, necrotizing encephalitis, autoimmune encephalitis. So even a child is a known case of epilepsy. Maybe the child has missed the 1 or 2 drug. It may be because the part of epilepsy, but we should also consider it may be the another etiology than the child's own primary disease. So all the children with status epilepticus, they need to be properly managed at the level 3 ICU. So these are the children who need a proper critical care management. They may need neuroimaging also, MRI and everything to be done.
Yes,
So
yeah.
this child, so stabilize the child and transfer as early as possible. That will be my message.
Very rightly said, sir, because seizures now we are seeing that many a times CSF and all those tests are needed. So one needs to be very clear about that. Can I ask moderator, like, do we have time for the 4th case? Should I go ahead? Jigen bhai, Kunal sir.
कितने मिनट लागसे?
Last case, it's about the poisoning, 10 minutes or so.
Yes, you can go.
Yes, yes, करी ली.
Okay, Fine. So this is a 6-year-old boy in a remote periphery. This child came to us from Modasa. He accidentally ingested pesticide, village near the Modasa, was rushed to the hospital and had all the features of excessive, because of the OP poisoning, had vomiting, excessive salivation, drowsiness, difficulty in breathing. And on examination, child was drowsy, tachycardic, respiration, tachypneic, saturations not maintaining. There were crepes, there were V's, pinpoint pupils, drowsiness, and no focal deficit. So my question to Shivam is ki, like, when one should think about the poisoning, number one. Number two, how to recognize this particular case if not all the features are there. Many times snake bite and that sort of emergencies, you tend to get misguided. So what are the warning signs or recognizing points, and what action particularly you will take for this child? Dr. Shivam.
Yes. So first of all, in case of usually some poisoning ingestion or something, we first mainly try to get if there is some any unusual smell coming from the patient. If it is OP poisoning or something, there is a typical smell for that. But for many other cases, there may not be any smell. So history becomes quite important. How did this start? So whether the child someone it's some most of the cases it is found sometimes, usually in children it is accidental. So their parents have found him such. So that times it becomes difficult that what has caused this. So particularly in still taking history is more important, and similarly examination for this child. As sir has rightly said, all the examination which is in pinpoint pupils, tachycardia, secretions are high, bronchoria is present. So we would look for first is the smell, then we'll go for cholinergic symptoms like sludge and BBB, the salivation, lacrimation, urination, diarrhea, GI upset, emesis, bradycardia, bronchoria, bronchospasm. Pinpoint pupils is quite pathognomic, and muscle fasciculations, weakness, respiratory distress, sometimes altered consciousness in severe cases is seen. And for the second part, what immediate actions we should take? First of all is the airway. Suction the secretions, give oxygen support. For OP poisoning, particularly atropine, 0.02 mg per kg every 5 to 10 minutes, till there is dry mouth or tachycardia, and continue it in infusion if required. If available, pralidoxime, usually not available in office practice, but still if it is available, it is 25 to 50 mg per kg, slowly IV for around 30 minutes. Keep monitoring for respiratory fatigue, seizures. Initially need to take IV access, oxygen support, and lastly decontaminate skin and clothes, protect other healthcare professionals from the exposure, and most importantly, medical legal notification case. So MLC has to be notified.
Right, Shivam bhai. For this particular child, symptoms were screaming out the diagnosis, but many a times things are not that clear. So whenever there is an hyperacute event, then we know it's either poisoning, accident, or vascular event that are very dramatic. At one moment, child was fine playing, and when he comes in, child is not well. So these are the signs. Immediate action, you almost mentioned everything, because here again every minute counts, and if you are not treating it medico legally also, later on this, I remember a case when I was in Hyderabad Rainbow, that aunt was giving a poison to a child, gave poison to a child, and later on all those things came out. So make sure that we document everything. So now Himanshu sir, now this particular child, you started with more atropine, OP poisoning case. What will you consider monitoring for this patient?
So basically, once we start the managing a case of OP where the atropine and pralidoxime is given, so clinically, three things we have to monitor. First thing, most important, is the maintenance of hemodynamics. Like, what about the child's heart rate, blood pressure, and vitals are stabilizing and improving or not. Second thing, the endpoints of or response to the therapy. So the improvement, the pupillary reaction start improving, secretion, especially the secretion start decreasing. So the monitoring the reversal of toxin, the OP signs, and vitals and hemodynamic monitoring, and simultaneously monitoring for the end organ function, like whether other organ systems are affected, like cardiac toxicity or lungs are still flooded, renal function is okay. So just overview, monitoring the vitals, reversal of the any toxidrome symptoms with the particular antidote and therapy, and end organ monitoring. That has to be done as a overall general principles.
Very well said, sir. Like for any other emergency, your ABC takes the precedence. Apart from that, any other organ dysfunction is setting it or not. Even in poisoning, we look into that. Shivam bhai, like when would you consider referring this child and where would you refer?
So, for referring persistent distress, need for atropine infusion, if mechanical ventilation is not available at our place, and also altered mental status, hypoxia, and seizures. These are the cases when we have to refer this child. Where to refer would be a tertiary care center, particularly ventilation care is available, and also long such cases may sometimes land up into chronic illnesses due to muscular fatigue and all, and myopathy, neuropathy may also occur. So such occupational therapy must also be available at such places.
Very rightly said. Many a time if there is a snake bite, or then you have to speak to the treating point where do they have anti-snake venom or not. Recently we got a child with diphtheria where ADS we could not arrange, and that sort of communication is very important. So as you rightly said, so wherever or we are referring, we make sure to make a point to speak to the receiving doctor. Hiren sir, for this poisoning child, any particular uh, thing which you should be considering while transporting?
First, our priority at our setup was to, at the receiving center, was to have the parameters stabilized. Because એવું નહીં કે આવ્યું ને ફટફટ serious છે લઈને ભાગો. So
Right.
on the way you may lose the child. So our priority is already narrated to stabilize the child. So take a time to stabilize the child and then prepare yourself to transport this child, because such child, if child is on atropine, so you need some staff. You can on the way administer the atropine, or you have to start the atropine infusion as well, which needs to be monitored in view of atropinization, whether it is overall proper atropinization is persistently maintained. So that preparation you have to done. If child is not given palm initially, and now you can manage. If you have not time to give 30 minutes to give at your center, you can give on the way as well, if you have well-trained staff to accompany this child. So that can be done on the way, along with the routine required live oxygen support and this IV fluids administration continuously. You need to monitor the vitals as well on the way, and if possible try to have some suction facility as well, so that frothing and that don't disturb the us. Along with that, if we have to be careful about this product if they have brought with us, so ask relative to carry that with along with them, so that receiving
Right,
center
sir.
can also be aware that what actual product it was consumed. આની અંદર તો ઓપી પોઈઝનિંગ ની અંદર આ બાજુ મોડાસાનું પેશન્ટ છે એવું અમારે ત્યાં પણ there is lot of patients coming, children maybe accidentally or intensely ને
Right.
in that case, uh, even though you have treated for 1 minute or just seen in the OPD and you have referred, you need to document everything, because this is a MLC case, and along with the proper documentation you have to provide the copy, forward the records as well to the center where you are referring, to maintain the continuity. ઘણી વખત એવું થાય કંજનભાઈ, એક વખત 5 વર્ષ પછી કોર્ટમાંથી તારીખ આવી મારે,
અરે બાપરે.
ખાલી એની અંદર
Yeah.
એટલું જ લખેલું હોય કે કેસ નંબર આ ને આ તારીખે તમારે એવિડન્સ તરીકે એક્સપર્ટ એવિડન્સ માટે આવવાનું છે. હવે જો એ વખતે તમે પ્રોપર અલગથી એમએલસી નું મેન્ટેન કરેલું ના હોય તો તમને ખબર જ ના હોય કે વોટ ઇઝ એકચ્યુઅલ ધીસ કેસ, કારણ કે એની અંદર કોર્ટના સમન્સમાં કશું લખેલું જ નહીં હોતું બીજી ડિટેલ્સ. So you have to find
Right.
out also. So if possible, also take a backup from this police or court, okay, which was the case number as well, and mark that your file with that case number as well, so that you will be well prepared in future this court summons and all that as well. Yeah. So
Very rightly, sir. You mentioned each and everything. Now I'll come to Nirmal sir. Like any poisoning or undiagnosed kid, like where we don't know what exactly it is happening, and that child. So how would you proceed with that?
Kunjan, see what I was just thinking that in tier 1 and tier 2 cities nowadays we are hardly seeing OP poisoning. See, in our unit we admit more than 600 children every year, and for last 4 5 years I have not admitted a single case of OP poisoning. So maybe at the village level or level 3 tier cities, tier 3 cities must be there.
Yes,
But any poisoning means one thing, if the diagnosis is not clear of what is the underlying cause, we see the pediatric assessment triangle, airway, breathing, circulation, it is affected, but there is no clear cause which we cannot identify. Always suspect there can be some intoxication. See, what we are seeing nowadays is more of a accidental ingestion of the medicine, household
right.
medicine. See, the grandparents are taking some anti-hypertensive drug or anti-diabetic drug. So these are the drugs child has consumed. So we are coming across these cases, maybe 5 7 cases every year we see where the accidental drug is consumed, a child between 1 to 3 years of age. So that is the most common. So we must always suspect there may be some underlying cause. So if that is the case, then we can do the sampling and get the toxin level done or the drug level done, what kind of toxin can be. But always have a high suspicion. As you told about one case where it was something like a homicidal try of case, some aunt intoxicated the child. Similarly, I had for 25 years similar kind of history. First 2 times, I also missed the diagnosis of OP intoxication. But the altered sensorium, the child was doing well. So no classical toxidrome or the signs. The first 2 times, I just couldn't come to the diagnosis. Third time when the child was brought, and by the smell I could feel it is something OP. And then I realized all the 3 times, the aunt of the child was given the OP because she was not having child and the sister-in-law is what got the
Same
child.
story.
And
Same
some of that
story.
jealousy. She was.
Yeah.
So I think it's very, very important. Always suspect that something can be a foul play. So always keep in mind. See. But first thing, I
Right.
think airway, breathing, circulation, try to maintain, and the diagnosis may come up. See. But all cases where you cannot come to a diagnosis,
Right.
after doing all complete workup, always suspect there can be some intoxication or some drugs can be consumed by the child. I think otherwise the part is very well covered.
Okay. Thank you, sir. Thank you for giving the learning messages like to identify, treat fast, and treat right is important. And we have to monitor closely, refer to the right place, and transport safely. So these were the take-home messages were being stressed upon by the expert and the panelist. Over to you, Jigen bhai and Kunal sir.
One minute, Kanjal.
Yes, sir.
In this last slide too, the one thing what Dr. Nirmal sir emphasized, that consent,
Right.
informed consent is audiovisual consent is must for a transport of critically ill child. Consent is has to be included in this. Yes, yes,
Right, sir. Right. Agree.
yeah. Thanks.
Thanks.
Consent and counseling. See,
Yes,
the most
counseling and
important is
consent.
the
Yes.
people managing critical. Yeah, counseling has to be very well counseling. And we should not lose the patience. In spite of the parents attending, asking questions again and again, we should keep ourselves very cool.
Yes, sir.
We have to answer all their questions properly. See, our scenario, 10 people will come at a time and they will ask the question. Okay, ask them to sit them quietly. Okay, and keep answering. But I have seen whatever may be the critical cases there, if we do a proper counseling, then we don't face more challenges.
Right, sir. Very right, sir.
And sir, one more thing actually.
हाँ बोलो आप ठीक है.
हाँ देख भाई बोलो.
One more thing. What happens? What pediatrician routine habits are like if child is in seizures or maybe raised ICP is there, or maybe like septic shock, or maybe respiratory distress. But if saturation is when melting, they're not intubating. They're very much afraid of intubating the child and shifting. So most of the time we heard of emergency like child has collapsed in between the way and then child came broad dead. So that is very also important take home message. If it is a long term transport call, if any 3 or 4 cases like that, better to intubate either by pediatrician or maybe you can take help of anesthetists and can shift the child. So child will be shifted safely. So
Hardik bhai, to add on this, Hardik bhai, to add on this, if you are not well versed with the intubation, then you have keep ready laryngeal mask is a good
laryngeal
option.
airway, yes, sir, yes, sir. That is also option. We can put
Yes.
laryngeal airway
So
mask
it's
and then
easy
we
to
can give.
yes.
So that is the most of the time mistakes happens and most of the child become broad dead while the transportation in between only and become hypoxic injury sometimes.
Jigen bhai.
So thank you all for Best Academic Fest today. Khanjan bhai, well, very good moderating the session and crisp and clear messages by all our panelists and experts. Request Dr. Samir Shah sir to give vote of thanks. Samir bhai, present show.
Yes, fully. So it's a really excellent presentation by all the panelists and excellent moderation by Khanjan. It's a really eye-opening for the many of the us while we are handling such type of the problems in the OPD base, and because of the limited availability of the resource material, not only resource material but the trained staff and time, and of course the instrument. So these all things that we have to keep ready while handling such type of the OPD, because it's now really a necessity for the any OPD that basic things should be available to handle before they refer the child, just standing them without any intervention. So it's a really nice discussion and it's a time to close. So I sincerely thank each and everyone who have remained present, including my MOCs, Dr. Jigen Sir and Kunal Sir, for the excellent moderation. Thank you once again. Thank you.
Thank you.
Thank you,
Thank
sir.
you, everybody.
Thank you, everybody.
Thank you,
Thank
everybody.
everyone.
Good night.
Good night. Good night.
Thank
Good
you.
night. Good night.
Good night.
Good night.
Good night.